Everyone says do more UWorld to score higher. If that worked, we'd all get 260s. I had a student who failed step 1. 2 months later, using the exact same materials, he scored in the top 3%. Nothing changed except how he reviewed questions. In this video, you'll watch me coach a student through NBME-style questions using the exact method that adds 30+ points to your score. No extra studying, no new resources, just a better way to use knowledge you already have. One of the things that we found is that if you, so a standalone question obviously is, it stands alone because if I were to come up to you on the street and say like, okay, like, just ask you a question, it should be able to stand on its own. In other words, you wouldn't have to know the vignette, you wouldn't have to know the answer choices. You should be able to, knowing just the question that I gave you, know what the answer is, as long as you have the knowledge. One of the best ways of, so that's sort of the standard, right? Is like, can you do that? Mm-hmm. One thing that we found is that, like, if I were to just ask you what the standalone question is for all of the questions on your test, you would probably increase your score by at least 20 or 30 points, easy.
Yeah.
Right. In other words, like, if you could just kind of sweep away all of the interpretation stuff and like it was just based on your knowledge, you would see a pretty dramatic improvement. And so the standalone question is a really useful tool because it very quickly encapsulates, do you understand what this question was about? And so that's why I love it as an activity, because if you have a good standalone question, like, I already know that you interpreted the question correctly, like you probably got the knowledge for it. Like there's so many things that you have to be able to do in order to create a good standalone question.
Right. Correct.
So let's go through, and I was kind of briefly looking through your document. Perfect. So one of my favorite, so this is a management question. So up to 40% of the questions on your test are going to be management questions. One of my favorite ways to go through a management question, so management questions, to take a step back, you need to know A, what's the diagnosis, and B, what's the severity. Right. So your standalone question is going to basically have those two things, right? So it should include both the severity and the diagnosis.
Okay.
So one of the things that I love to do is to look, okay, so the answer was D and you picked A.
Yeah.
Great. Excellent. All right, so if you look at the answer choice that was correct,
right,
one of my favorite things to do is try to guess what the severity was.
Oh.
Does that make sense?
Oh, yeah.
So
yeah,
if the answer was...
That makes it crystal clear. D is obviously the most severe case, whereas
yes.
A is maybe like
yes.
not there yet.
Exactly. So I can guess at what the severity was. Like if I go back and I look at this question, I'm going to guess that there is a ton of severity clues telling me that this is really bad. Right? So let's see. So, okay, admitted to the ICU. This is like, this is like, if your admission is to the ICU, that's pretty bad.
That's pretty bad, yeah.
Right? It's like, that's kind of like the equivalent of being brought to the ED. Like this may be worse.
Yeah.
Massive subarachnoid hemorrhage while jogging. Oh my God, right? Emergency neurosurgery, no signs of neurologic recovery. Okay, great. On hospital day 4, oh yeah. So she's like, so they're giving you a bunch of signs that she's basically brain dead.
Right, yeah, yep.
And they've told you that there's no reversible causes, right? Like so they're going through the criteria for brain death.
Mm-hmm. Yep.
Right, so there's like no brainstem function, there's no cortical, there's no like other signs of like cortical function, and then there's no reversible causes.
Right.
So you pretty much covered the entire base, all of your bases.
Mm-hmm.
And so that's, so yeah. So what would this, what's the next step? Is clinically brain dead, but only request for care to continue. So how could you sort of simplify that?
How would I simplify it? I would probably
because your standalone questions I think were a bit long.
I would take out the last bit, be like, what is the next step in management for a patient who is clinically brain dead? Like,
yeah,
I think
essentially,
yeah, because whether the family requests for care or not, the main point of this vignette is the patient is clinically brain dead. So like you as a physician, what do you have to do next? Oh man.
Yeah, exactly. Right. I mean, another way of saying it is like, what do you do for, you know, like sort of futility, like medical
Right.
futility?
Correct. Yeah. At that point, yeah, any care is futile. Yeah.
But that's essentially it. And so one of my favorite, and that's why I love doing management questions for standalone questions, is because you can pretty much guess. I'd say like 95% of the time, if you look at the answer, you should be able to look back and be like, oh, okay, I get it. Like I'm pretty sure I know what the severity will be.
I see. I see. Okay.
So we'll see if we
That's
can
a
do that.
nice skill. I haven't put that to action, so I'm gonna take that on.
Anything else on this one?
No. That particular skill made the answer kind of really pop out. Like it's no question. Like it's D, not.
The other thing that I would say is that rule in and rule out probably would have helped for this one as well.
Okay.
Right? Because what would the rule in for A be? Like under what circumstance would that be the correct answer?
If the patient was still alive, but maybe they're going in a direction where it's not as promising for recovery, and in the case something were to happen, we want to be prepared. So, do you, like you as the family member, next of kin, would you like us to take heroic measures if that hypothetically did happen or not? So that would be
Right.
when A would be more of a rule in, but that's not the
exactly.
case here, right?
Because for management questions, one of the best things that you can do is to ask yourself, like, what would this be the correct answer for?
I see.
Because in the vast majority of cases, that is the correct answer for something, right? Or it represents something else. Like B, I don't know. I mean, step 2 in shelf exams, it's not, you can't use this quite as often. Step 1, it's like almost certain. If the answer is ever like ask someone else or, you know, refer them to your colleague, or that is almost never the answer. Okay. Right? Like pass the buck, at least on these exams. Again, like it's different, you know, maybe different in clinical practice, but that is almost never the answer for these questions. And if, again, your goal is to try to peel back the layers and get to the core of what the answer is actually saying.
Okay.
That makes sense?
I see. Okay.
And then kind of like it's not gonna happen. So again, same thing. I think if you had done rule in and rule out for these, you would have been able to say like, okay, well, A would make sense if like it does. The rule in is like you would do this if it was not clearly futile. Might be the answer if it was like kind of like ambiguous, right? If the severity wasn't quite so bad. Right, you got like the elderly patient where it's like, yeah, things are looking not great, but like you never know, like maybe they do kind of pull through. Right? May not be like the kind of quality of life that everyone wants, but yeah, you know, it's like kind of like a little bit more ambiguous. Whereas this is like, it's been 4 days.
It's clear,
their brain has not come back.
Yeah.
Like, pretty quick. Cool.
Got it. Yes.
All right, let's look at this. Oh, great, management question. Perfect. All right, so you see how it's like your standalone questions are, I think, too detailed. Yeah. There's just too much. So the answer was TSH. Oh, I see. Oh, it's maybe a little different. Never mind. Yeah, this might be fair. So TSH.
Well, I am curious though, because for this one I did have trouble making it more succinct, and I was curious to pick your brain on how I could have made it more succinct. Because I admit it is a bit wordy.
Oh, I see. I mean, really, they're just saying, what's the next, like, how do you diagnose thyrotoxicosis?
Oh, wow. Right? Oh, yeah.
So there's kind of 2 parts. Again, for all management questions, you need to know what's the diagnosis and what's the severity. So if you know the diagnosis, like, okay, well, this sounds like thyrotoxicosis, then it's pretty straightforward what the question is. It's just going to be, what do you do to diagnose that thing? Let's look at the next one. Oh, I see. Yeah. Kind of the same thing. So I think I know what based on your question, I think I know what the answer is. Defer repair it due to, yeah, exactly. Okay, great. So this is a kind of a management question, yeah?
Yes.
So again, I like to play the game of let's look at the answer and let's try to go back and see what is the severity. Let's try to predict the severity.
Right.
So if the answer is don't do surgery because they are an awful surgical candidate, what's the severity?
It's pretty bad.
Pretty awful,
Yeah.
right? It's got to be pretty bad. And based on your standalone question, I think you understood that. So what is this? So what would be the better standalone question for something like this? Because again, the idea is that you want to, like, you see how this, you're kind of getting mired in the details.
Mm-hmm.
Even this is kind of detailed. This is really detailed.
Right.
Right, really, like all of that stuff is just there to tell you that it's AFib, or thyrotoxic.
Yeah.
Right? This is just like too much. Like the fact that it's a large abdominal aortic aneurysm, like is this critical to making the standalone question? Could they have swapped that out with something else and still gotten the same kind of...
No, they could have swapped it up with another surgery, just like a...
Yeah, exactly. Or metastatic pancreatic cancer, like is that a critical thing? Or could they have swapped that out for some other like terminal, like really bad
They could
sort
have
of...
swapped it out too.
Okay, great. So now tell me, so we now know that these are kind of details, they're kind of missing the concept.
Yeah.
So now I want you to tell me what is the actual concept, and then tell me what the standalone question is based on that.
Should surgery be done in a patient who is a bad surgical candidate? I mean, that's kind of the concept.
Yeah, essentially. Yeah, essentially. Like, and not just that, but it's like, what is it? A large abdominal aortic aneurysm? Like, how big of a surgery is that? Like, what was the purpose of them putting that there?
Long.
A very involved surgery. Like, should you do a massive operation on someone that's going to die because of some other disease? That's like already going to die because of something else.
Right. No.
Like, that more or less is the standalone question. Does that make sense?
Yeah.
And so oftentimes when I talk to people that have just taken step 1 or step 2 and they walk out and they're like, oh my God, like my test was nothing like what it was predicted to be, or like what my UWorld questions were, what my NBMEs were. The reason is, I think in many cases, is that they are missing they missed the concept that was buried underneath the details. Mm-hmm. So a large abdominal aortic aneurysm is that's a detail. The concept that represents is massive surgery that is a really big whack. Right? Metastatic pancreatic cancer is a detail. It is a detail that represents the deeper concept of like, they're gonna die of this thing.
Right.
And so you have to understand that you have to be able to extract away, because I think you're seeing the trees and you're missing the forest.
Right. Correct.
That make sense? Kind of fun, yeah?
Yeah, no, and it's funny taking a step back and seeing, it's funny being a more relaxed version of myself and seeing the stressed version of myself do this, because this version of myself would actually pick up on that pretty fast. Right. But, it's just like in the moment, I'm just kind of like, and, oh man, okay, so got to practice the skill. So when in the moment, it's a little bit more like, easy to access, even when I am a little panicky or like not kind of centered. Okay.
That's exactly right. Yeah, that's exactly right. And it's also, I think, very, very, very instructive too, to see that a lot of, I think, the stress that people have when they're taking the test is not necessarily because the test itself is so hard, but because of all the extra stuff. All right, let's look at this. What is the cause of septic arthritis? That's actually not bad. Is that the hematogenous? Oh, I see. Yeah. Like, what's the mechanism of getting like septic arthritis?
So for this one, Dr. P, I do have to admit, this version of the standalone question was like the third version. My first version was actually very long-winded and just like very like a lot.
Yeah.
And then I challenged myself and I was like, actually, the standalone question is, what is the cause of septic arthritis?
Yes.
And then that's when, and then I had a moment, a come to Jesus moment. I was like, oh, then of course it's A, it's not D, you know.
Yeah.
But the previous version of my standalone question, it was a little iffy. Like maybe it's D, maybe it's A. So
Right. Exactly.
yeah,
But this is excellent. This is it. Like this is what it should look like.
right.
Right? It should be really tight, really conceptual.
Yeah,
Right? Like this is like it's you're missing the forest through the trees.
yes,
Right? You're like, what, like, should you do a massive surgery on someone that's going to die very soon of something else?
right.
Like that's essentially what they're asking. You know, it's like you want it to be very, very simple.
Yeah, yeah. Okay.
And you can see how the question becomes easier to answer if you can make it conceptual.
Correct.
Just like what you found here, right? Like this is easy. Like if someone has septic arthritis, like how did the bacteria get there?
Right. Got there through the
Like,
blood.
well, yeah, probably through the blood. Like
Yep.
that makes total sense,
Yep.
right? Whereas if you're like in a 71-year-old patient who presents to the emergency department who's had like left, like, what's the mechanism? You're like, oh, geez, I don't know. Right? So the more details that you have and the less conceptual it is, the harder you're making it for yourself.
Yeah.
Because you're kind of painting yourself into a corner where now it's like, oh, this is very, like, you have to have this very, very, very specific set of knowledge. It's the same kind of problem that I see when people rely a lot on pre-made Anki cards. Like those pre-made decks that kind of like float around. The challenge is that they come to see medicine as a series of facts to be memorized.
Oh, huh.
And they hope to find that pattern recognition of like, oh yeah, like that's right, like this is it, this is the thing.
Right.
But because there's so much noise and because the signal's weaker, it works okay for step one. I found like people that use like heavily pre-made decks to pass step one, like it's not very efficient because obviously to memorize every detail in medicine as if it's like a fact to be memorized, like it's very inefficient.
Yeah.
It's much easier to sort of see the concepts. But for step two, I rarely see people successfully using pre-made cards, at least solely using them.
Yeah.
And I think that is, I think that's one of the reasons is because like you have to put in so much extra work in order to anticipate every single possible scenario. Much easier to see the concepts. Okay, what's the following diagnosis? Great, hematuria and lytic bone lesion in an elderly. That's actually not bad.
Oh, really? Okay, I was hoping. Okay. Then maybe this one was. Maybe I didn't do rule in, rule out. I remember not doing rule in, rule out for this one.
Wait, so the answer was D, and you chose C?
Yeah.
What was your rationale for this one?
What was my rationale? So we have an elderly patient with kidney stuff going on and bone stuff going on. Oh, I think that happens in multiple myeloma. Let's just make that and move on.
I see.
Yeah. And then a lot of these, they're purely just bone related issues. So I kind of thought like, well, don't like A for that reason, don't like B for that reason. I actually didn't fully consider D at the moment. I think in the moment, actually I did consider D. The reason why I didn't think about it more critically is because I thought that potentially someone with metastatic carcinoma would be more sick. And so I kind of shied away from D. And then E and F I kind of shied away for the same reason. Like how would it explain the kidney thing going on? So
it sounds like you ruled out before you ruled in for D. You're like, nah, it can't be D because they would have been really sick.
Right.
As opposed to thinking, well, what would the metastatic cancer be? Well, if he had renal cell carcinoma, that would explain the hematuria, and if it metastasized to the bone, that would explain like the bone stuff.
Right.
Okay, that's the rule in. The rule out is, there's not a clear precipitant. Like, there's not a clear, like, they didn't make him a smoker, right, to make it easy on you.
Mm-hmm.
But that would be the major thing.
Yeah, no, I did. an abbreviated version of a rule in. I didn't do the full protocol. Took a shortcut.
Well, it sounds like you did the rule out.
Right.
Not necessarily the rule in. Yeah, this is tough. I mean, especially if they didn't give you like he was a smoker or he had like some kind of, you know.
They
so
didn't. Yeah.
that makes it harder for sure. So, but that's what I mean when I say that the signal is weaker and the noise is louder.
Yeah.
Right. So the signal's weaker. If this was a step one question, they would have made him a smoker. They would have probably led with like he has painless hematuria.
Right.
Oh, and by the way, he's got like, you know, so they would have given you kind of the classic presentation much sooner. This is like you have got to, like, you have to piece it together. You may not know it until, I mean, this is tough. This is hard. Like if that's all they're giving you is like hematuria and like leg pain and he's got like a lytic lesion, that's hard.
Yeah.
Right. And so rule in, rule out is a nice kind, again, it's a nice kind of safety valve.
Yeah.
So like, okay, if you didn't consider it, it's not unreasonable that you wouldn't have thought of the differential, put this on your differential as you were reading it. And so if you can, to avoid missing this, you would, having a rule in and forcing yourself to be like, okay, like how could I make sense of this? Right, and then the rule out.
Uh-huh.
Okay. Cool, make sense?
Yes.
Hematuria, yeah. That's pretty much it. Like this, I think, is the stand-on question. Yeah. This is kind of what, for diagnosis questions, that is kind of what the stand-on question is.
Okay.
Let's look at this one. Oh yeah. Oh, these are my favorite.
So this one was a bit of a train wreck. I remember working through this question and feeling like I was, pulling the hair, like pulling hair out.
This is really, okay, so these are really common questions. So next up in management. So the answer was D, weight loss, and you chose B, sleep study.
I chose B, yeah.
Oh, interesting. And this was the BMI in the question?
I believe the BMI in the question was not too far off from that. It wasn't in the 30s. It was in the high 20s.
Okay.
Yeah.
Interesting.
So another kind of like weak signal, right? I was kind of like, well, I mean, yeah, they could lose weight, but maybe sleeping more is going to help more for this patient than that. So I kind of, yeah.
So this is a harder one. Let me tell you the framework that I use for these kinds of questions generally, because this is a really common like shelf and sort of step 2 question, is like they'll give you 5 things, 3 of them might be risk factors, and you've got to figure out what's the most important risk factor. So there was this one question that I saw that was like, it was something like, it was a 67-year-old patient that had a BMI of like 17.
Oh.
And a 67-year-old woman.
Yeah.
That had a BMI of like 17. And the question was like, and she had osteoporosis or something like that. And they're like, which of the following is the most likely, like the biggest contributor to her getting osteoporosis? And the challenge is that both of those things technically, and one of the answer choices was age, and one of the answer choices was BMI.
Why do they do that to us?
And so, I know, it's like, why? Right? Like I used to struggle on those questions a lot. So there's a system that you can use to basically get these questions correct almost every time.
Okay.
What would be your gut instinct for that patient? Like what was the biggest thing? Was it age or BMI?
I mean, my gut reaction is the BMI. Like that makes me nervous. Totally,
makes total sense. So the answer was age. And so, but the person that I was working with chose BMI as well. So let me explain to you how you can get this question correct and know with confidence. Because again, this is much less about knowledge than it is about approach.
Okay.
And so you want to arrange the question, just like with standalone questions, you want to arrange the question in such a way that you can tap into the knowledge that you already have.
Okay.
Okay, so what do I mean? I mean that you should take the extreme versions of, or think of each of the different risk factors in isolation, and you compare the patient, like make that one risk factor the only thing that's wrong, and then make everything else normal.
Oh, okay.
So what do I mean? So in this case, I would say, who is at greater risk of having osteoporosis? A woman with a 25-year-old woman who has a BMI of 17, right? In other words, I've made the age normal and I've kept the BMI abnormal.
Low, yeah.
Or a woman who has a BMI of 22, right? Normal BMI, but she is 67.
Then it's the 67-year-old.
Yeah, but you see how it's so fast for you to answer that question?
Yeah.
Than the alternative?
Yes.
And so like, because I remember thinking like, oh my God, like how could you possibly know the answer to these questions? Like it's virtually impossible that you would know all of these different relative risk factors. Because you can't go with like, oh, well, smoking is always the bad one, right? Because like sometimes they'll say like, oh, well, they smoke like a cigarette a day, right? It's like, what do you do with that, right? And so the way that you deal with that is you just imagine in your head, okay, that thing that's abnormal, that's the only thing that's abnormal, and everything else is completely normal.
Make everything else normal. Okay.
Right? So let's try that for this one, right? So if you had a woman that had a BMI of 28, right? So she's in the overweight category, or you have a woman, but she sleeps 8 hours a night.
Right.
Or you've got a woman who sleeps 5 to 6 hours a night, but her BMI is 22. Like, who is at greater risk of having health issues?
The woman who's overweight.
Yeah, I mean, and if you think about it, like if you think about like the different sort of screening things that we do,
Yeah.
BMI is one of the things, not sleep.
Correct.
Because the other way that you can get the question like this correct, because again, what you want to avoid in all of these questions, what we're trying to avoid is painting ourselves into a corner where we're asking knowledge that we know that we don't have, like this one. If I asked this question to myself, there was a very good chance that I do not know the actual answer to that question. Like it has never come up in all of my training, and I have no intuition around that.
Yeah.
Whereas if I peel back the layers and I'm like, well, what if someone had like a massive, like, should I do a massive operation in someone who's like, has a very near terminal illness?
Yeah, that you've
like a terminal illness with a very, very poor prognosis, right? If I ask it that way, then I'm like, oh, well, boom, like I know that. Right? So same thing with this one, right? If I ask myself, okay, in a woman who is 26, has a BMI of 28.3, who like, if I ask it like that, like it's extremely difficult to answer that question. I need to simplify it and change it in such a way where I can take advantage of the things I already know. So what do I already know? Like, first of all, let's take advantage of the intuitions that I have. So I'm gonna isolate one variable and make everything else normal. Compare just the isolated variables against each other. And then two, I'm gonna think of like, what else do I know? So like, what are the things that I care about when a patient comes in? I don't recall ever seeing like, oh my gosh, like national guidelines around like, you have to get this much sleep or else like, stuff like that. At least really hardcore in primary care settings.
Right.
But absolutely is being overweight like a problem? Absolutely. Like that, like everyone knows that. Yeah. Does that make sense?
Yes.
So we're taking advantage of the things that we already know, as opposed to, right? As opposed to going through and being like, oh yeah, like I don't know, like I have no idea what the answer to this question could be.
Okay. So, okay, I got it. Okay. So the standalone question, in addition to it giving my brain less kind of stuff to deal with and like really distilling the real question that's being answered, it's also a way for me to tap into more directly tap into the knowledge that I do have. Because if with all this stuff, like I can get lost and lose that connection with my knowledge. So it's okay.
Just like we were talking about a few weeks ago, where you're like, oh, I want to just study more. I need to learn a little bit more. I need to cover a little bit more before I take my NBME. The reason why I said, no, you should probably take an NBME sooner rather than later is because the reasons why people miss questions are actually usually not the things that they are expecting, right? Like, For someone that's capable of getting a 260, which I think you are more than capable of doing it, if you don't get a 260, it's not going to be because you didn't have like good enough knowledge. Like if we look at these, I'd say that, I don't know, of the 7 questions that we've done, I mean, generously, maybe 2 of them were because of knowledge. Maybe, right? But even if we're really conservative and say like 4, like half of them were, which I don't think so, but like, but you see how like so much of it is about approach.
Right.
And it's about like, I keep kind of coming back to the same techniques, like context, chronology, severity, making a good standalone question, like really trying to simplify it so that you can bring in the knowledge that you have already, as opposed to painting yourself into a corner by asking a bunch of random details and getting lost in the trees. And doing the rule in and rule out so that you don't miss the answer that you didn't think of earlier. Let's do one more. So this next one I think is a great example. So again, management question. So I like to look at the answer. So the answer was incision and drainage. So I like to look at the answer and then I like to go back and say, okay, well, if the answer was, the like fastest thing, the like, some kind of like procedure arguably between D and E, like these are the most invasive. So I know because it's a relatively invasive, like fast thing, the severity must be pretty bad.
Yeah.
Right. And so,
okay.
What is a way that we could ask the question that is, and so I'm going to guess that like compromising. I mean, you already kind of said it in the question, so that's good. I mean, this is a fine question for someone who knows about airway stuff or ENT type stuff. Like this would be a reasonable question, but it's pretty detailed, right? So again, for a management question, the standalone question formula is, what is the management for severity, diagnosis? Meaning like, what is the management for blank severity or blank diagnosis? Meaning like, what is the management for really bad or very severe peritonsillar abscess, right? Do you see how that's probably an easier question to answer than like, what should you do if you've got an abscess that's compromising a patient's airway and they're 15 and they have some muffled speech, and like every single time you add in new details, you're making it seem like you need to have more knowledge to answer the question than you probably do. Yeah, it's sort of the expectation problem, right? It's like if you go in with the expectation that the answer is going to feel perfect, you're going to be very disappointed and very stressed out on most of the questions on shelf exams in step 2, right? Same thing, if you go in with the expectation that the more details that you put into the question, the better you're going to do, the worse you're going to feel, right? Whereas if you go in with the expectation of like, oh, okay, it's going to feel kind of icky,
right, exactly.
For some of these questions, right? Like it's like going into, if you go into a workout knowing like this is going to be the worst workout of your life, again, this is not going to be the worst test you've ever taken, but like point being, if you go in with the expectation that like, hey, this is going to feel kind of hairy, when it feels hairy, you're not going to take it personally. You're not going to think, you're not going to panic, right? You're just going to walk in and be like, okay, great, like game on, let's do it. That's how you turn missed questions into 30+ points. But there are 10 hidden score killers that wreck step 2 performance, even if you review perfectly. Like why 1 in 4 students score way different than their NBME predicted, or why your test day feelings are actually lying to you. I break down all 10 in the next video, including NBME data they stopped publishing. Click here to see what's really killing your score.